So I led off with this as one of the main take-home points, and that's that pulmonary hypertension is suggested by many, many clues, but diagnosed by right heart catheterization. So when you see your patient with dyspnea who comes into the office, EKG is readily available. Most people are going to have it. It's abnormal in about 80% of patients at diagnosis. And so how is it abnormal? They've got right axis deviation. They've got a big right atrium. The S1Q3, T3 is not just for pulmonary embolism, it's any kind of right heart strain. Another thing that a lot of people find their way to if they're coming in with shortness of breath, we can all imagine that if this was a patient with left heart failure, you would see curly B lines, you would see pulmonary edema. It also shows really quiet parenchyma. There's no curly B lines, there was no pulmonary edema. A lot of people find their way to a CT. The ratio of the pulmonary artery to the aorta on a CT, if it's greater than 1, so anytime the PA is bigger than the aorta, anytime that pressure system, which should have a pressure of 20/10, is bigger than that pressure system, which should have a pressure of 120/80, that's abnormal. Again, it doesn't tell you it's pulmonary arterial hypertension, but it does tell you that the pulmonary pressures are probably elevated if it's bigger than the aorta. The echocardiogram is a lot of times the way that people find their way to a diagnosis of pulmonary hypertension. And a lot of times the way that people are diagnosed with pulmonary arterial hypertension, whether that's the correct diagnosis or not.